All right, since we have already a full house, we are going to get started. I'm going to start by sharing today's Grand Rounds links so that people can get credits for the Grand Rounds CME and MOC. The Grand Rounds CME credits can be obtained by texting 25673 to the number 888-816-4893 as an SMS message. And if you are a physician, you can also get MOC credit. For that, you'll have to first get the CME credit, and then you have a link here which will be displayed back again. And there will be a room code, Future 2025, you can use to go and answer the questions. And if you answer the questions correctly, and if you have an existing ABIM account, your MOC will be directly linked to the ABIM account, which is linked to your Cloud CME profile. So once again, please complete the CME and then complete the MOC. And you have also the barcode here you can use to directly take you to the landing pages. With that, I'm very happy today to bring back Dr. Kameshwari Maganti. Dr. Maganti is very well known to all of us. She is section chief of non-invasive cardiology, and she's a professor of medicine. Many of you who have joined new may not have met her as yet, but it's an honor. It's been an honor for us to have her lead the section. She came in from Northwestern University from Chicago, and her beginning was with her education in Guntur Medical College in India, and subsequently her internship was in Chicago, followed by clinical cardiology fellowship at University of Nebraska, and also at Northwestern University. She had also a research fellowship with Dr. Kanu Chatterjee at University of California, San Francisco. Subsequently, she came to her faculty appointment at Northwestern University Feinberg School of Medicine as clinical instructor in 2003, and rose to several academic roles as a teacher and director of the cardiovascular service line solid organ transplantation program. And she was also subsequently known for her work in national societies. Particularly, she has played pivotal role in American Medical Association as a delegate member, and she has also played important roles in several steering committees at American Society of Echocardiography. She's currently the board of directors of the American Society of Echocardiography. She has profound interest in almost every aspects of cardiovascular imaging, and with a focus on ultrasound, cardiovascular ultrasound. And there is a special connection that was there between me and her that actually allowed me to explore the options for her to be invited here. So, and this is premise of today's Grand Rounds, and I would be very happy to tell you. So my connection with Dr. Maganti began when I was actually a research fellow at Mayo Clinic, and I was awarded a Young Investigator Award. She was a referee for my work, and I did not know about that. And subsequently, she connected with me and was asked to write a write-up about how research awards propel people's career. And I'm really thankful for the break that award provided to my career. It was instrumental for bringing me to the innovation platform. Subsequently, during my innovation journey at different centers, and particularly through the American Society of Echocardiography, there came a time where I took a keen interest in point-of-care ultrasound, and she participated in a large mission program as a remote reader from India when we were doing screening using point-of-care ultrasound. And this is about 10 or 12 years back, where we created a cloud-based platform for remote reading, where thousands of point-of-care ultrasounds done on camps, screening camps from India, remote corners, were uploaded, and then they were read elsewhere. This innovation spirit continued and has been an area of fascinating conversation that continued to evolve between me and her, plus her personal connection with me and my family whenever she would travel to India, particularly with my mother. So when I came to Rutgers and I happened to meet her at ACC, I really sought out if there was a way we could bring her here, and she really jumped up with the idea. But I think central to that theme was that she knew the spirit of innovation, and she was really interested and looking forward to developing a program and helping us build the innovation platform. And with that, when the opportunity came for us to innovate, particularly in point-of-care ultrasound, and when we brought it here, I was so pleased that she took the lead in developing a clinical trial that is making some important headlines and was presented as a late-breaking clinical trial last month in December in Berlin. With that, today I'm inviting Dr. Maganti to tell us about the role of POCUS, and then she will dwell a little bit more about the specifics of the clinical trial that we found some very interesting idea. But it is all about teamwork, collaboration, and innovation. Kamu, welcome.
Thank you so much, Partho. I'm very blessed to have come to the institution, and thank you so much. It has been a great journey, and I'm sure it'll continue to be a great journey. So with that, I'm going to share my screen. I hope you all can see my screen.
Yes.
Okay. Well, today, as Dr. Sengupta mentioned, the POCUS or point of care ultrasound is something that a lot of us can do at the bedside. And I think we are just going to go over what exactly we do with POCUS and then move over to some of the research applications, especially the research application that happened here at our institution. So I have no disclosures pertaining to this presentation. So the primary learning objectives for the grand rounds is going to be what POCUS exactly is, what some of the POCUS applications are, and what is cardiopulmonary POCUS, and I'm sure a lot of you may be hearing about that, and how do we leverage cardiopulmonary POCUS into daily practice, and what are the other exciting applications that are there on the horizon. So point of care ultrasound exam is diagnostic ultrasonography that is performed and interpreted by an attending physician just at the patient bedside. Anybody can do it. It can be used in clinical situations to aid in making a diagnosis or even provide a qualitative assessment of the patient. And the advantages are very easy because it's very non-invasive, it's very quick, you get immediate result. You can do dynamic assessment, especially when it comes to volumes, looking at the RV. It allows for serial monitoring, which is one of the key things that we can remember, especially in an area such as heart failure. Some of the disadvantages is it's highly user dependent. So if somebody is not well trained, then you may not be able to get diagnostic images. It doesn't provide complete quantitation yet. It has a lot of bells and whistles already built into it, but not everything. And I'll go over some of that as well. Whereas for cardiologists, POCUS helps us identify volume status, to quickly rule out tamponade, to look for type A dissections, to look at LV and RV failure, to look at RV strain, and to look for severe valvulopathies such as acute MR and acute AR, and aortic stenosis as well. So there is a little bit of nomenclature that we all have to know. So one of the adjuncts that we can do in the clinic setting as an adjunct to the clinical examination, and if you use POCUS with or without a stethoscope, it is called ultrasound-assisted physical exam. And the nomenclature is really important because this is just utilized as a simple add-on to what you normally do. And it is focused, and you can do repeatable assessments as well. Then if you use it as cardiac POCUS, it's going to answer clinical questions for diagnostic purposes. And there is both basic cardiac POCUS or focus. Focus is just focused exam, or advanced cardiac POCUS, which will include the critical care echo as well as targeted neonatal echo. And then, of course, there is consultative echocardiography, which is the card-based, which can either be comprehensive or limited. So it is a very standard practice in emergency, obstetric, and musculoskeletal medicine. It has actually gone into family practice, internal medicine, as well as even nephrology. It allows integration, obviously, of sonographic findings with the history and clinical exam. And these are some of the current POCUS devices. And there are many more, out of which you may recognize Butterfly, because we do have some butterflies at our institution. You will recognize the V-Scan made by GE and Lumify made by Philips. When a survey was given, it was thought that the mind rays seemed to be giving the best pictures. And then Cosmos, surprisingly, I gather, is extremely easy to use. So honestly, if you ask me, I think all of them give diagnostic quality images, and some of them have prescriptive guidance, which is AI guidance built into it. So even a novice person would be able to use it. And currently that is available on the V-Scan. And I heard through the grapevine that it'll be coming into Butterfly as well. So a high school student can pick up one of these probes, and then they can just go onto the chest and it'll tell them, hey, you're in the right spot, or no, you're not in the right spot. And you can get pretty good diagnostic quality images when you have prescriptive guidance. So as we have talked about, the POCUS applications are plenty. We talked about some of the cardiac, the pulmonary, where we can look at pulmonary edema, which is what we are most interested in. And it can be utilized to diagnose pneumothorax, pneumonia, obviously for rib fractures as well. And then if you look at OB applications, gestational age, looking for ectopic pregnancy. And then for GI applications, hydronephrosis, cholelithiasis, appendicitis, musculoskeletal, where you can actually detect and drain abscesses. You can look at soft tissue infections as well. And then lastly, vascular applications, where you can look at carotids. You can look for ventricular thromboembolism, venous thromboembolism. So to rule out or rule in DVTs, people can sometimes use it. But let us look at one of the cases that we had recently at our institution. This was a 73-year-old woman who presented with a STEMI. She underwent a very successful prox to mid LAD PCI with a drug-eluting stent approximately 2 months ago. I am sorry that it stopped moving. Let me see if it'll move now. I think it is being a little slow, but maybe it'll load and start moving. It moved just a little while ago. A transthoracic echo following the PCI demonstrated normal LV size and function. There were no regional wall motion abnormalities. She was sent home on DAPT. She now presented with 8 to 10 out of 10 chest pain that was unremitting. And there was interruption in DAPT due to recent COVID infection, for which she was admitted at an outside hospital. And the bedside echo demonstrated a wall motion abnormalities, especially in the apex, with akinesis of the apex, which could be seen both on the 4-chamber as well as the 2-chamber. Cardiac cath lab was emergently activated due to concern for instant thrombosis. And there was a large thrombus burden. Patient underwent mechanical thrombectomy of prox to mid LAD and a redo stenting. Thank you, Dr. Wong, for doing that. Patient got her intervention within an hour of presentation. So here you can see how quickly POCUS has aided her care. So people always keep asking me, what are the right kinds of transducers? So the transducer that we utilize is a phased array transducer for cardiac applications for most part. And this can look at the LV and RV size and function. It can actually look at pulse wave Doppler to evaluate stroke volume. You can calculate cardiac output. You can measure PA systolic pressure. You can look for pericardial effusions, especially if there is a concern for tamponade physiology. For lung exam, we are talking about cardiovascular POCUS here. We are most interested as cardiologists in looking at B lines, and for which you could either use a phased array, you can actually use a curvilinear or even a flat transducer, all of which will allow you to evaluate the lungs. And then you can use the same phased array transducer to look for IVC collapsibility. That is the vascular aspect of the cardiovascular POCUS. How do we perform a cardiovascular POCUS? Since it can be done on the bedside, you just have to get one of the smart devices. You have to make sure the patient understands what you're doing, and then allow them to lie down in the left lateral decubitus position or any comfortable position. And then you just go over the sequences, the cardiac protocol, looking at the IVC and looking at the lung POCUS as well. You can store them in the cloud after you disconnect the probe and upload the images into the cloud. And these can be interpreted. These can also be reported because we do have a code, billing code for them. And these findings can help not only aid in diagnosis, but also the management. And there are many other things that can be done. You can do this at home. Not that I would recommend that for everybody or the patient's family, but we might come to that. And then telemedicine, the patient can do it on themselves. And of course, the inpatient and outpatient, where we have the most robust applications at this point. I also don't want too many worried well patients who will be imaging themselves every day, uploading it to us and asking us to look at those images. So we just have to be careful as to how you implement POCUS when it comes to a population level. So what are the indications for lung and IVC ultrasound? So the most common indication is shortness of breath. And of course, if people have recurrent pneumonias or even a really bad pneumonia, cardiogenic pulmonary edema, ARDS, COPD, and asthma exacerbations, pneumothorax, all of these can actually be looked at either by the emergency room physician or a PCP at the patient bedside. Some of the limitations is subcutaneous emphysema or even COPD and episematous lungs. People have to remember that ultrasound doesn't go through air, so we have to be careful about some of these limitations. If somebody has severe obesity or very skinny with very prominent ribs, you can't get into the rib spaces for us to be able to take images. If there are surgical dressings, exactly where you would scan, or if there is an open chest or chest wounds, it's going to be difficult to do this. If there are devices, if there are defibrillator pads, if the patient is on mechanical ventilation, it is a challenge. And if folks are not really well trained in POCUS imaging, or if there is lack of built-in prescriptive guidance in the handheld devices, sometimes that is a huge limitation if it's a novice user. Lung ultrasound can be done multiple ways. Remember, there are 3 lobes on the right lung and only 2 lobes in the right. So we typically divide it into 3 lobes on the right side, right upper, right middle, right lower, just arbitrarily. Then in the posterior side, left upper, left lower, right upper, right lower. And then you use your anterior axillary line and you can further subdivide. But there are multiple easy protocols, and some of the protocols we utilized have been just R1, R2, R3, R4. And the same thing is mimicked on the left side, L1, L2, L3, L4. And so these are propositions with the corresponding lung fields as well. So, one of the most common things we need to recognize is, first of all, whether the lung is aerated or not. As part of that, you can see lung tissue here, and we call this a bat wing sign. You can see the pleura, and the pleura is moving quite a bit here, and we'll go over some of that as well. I have more images to show you. And then you can see the rib shadows casting 2 shadows here. And those are the wings of the bat. And then these are called A lines, and the A lines are nothing but reverberation artifacts from the pleural line. And so in the middle is the lung tissue. And here it looks as though there are multiple ants just crawling in a line, and this is called lung sliding. It is the motion of the visceral and parietal pleura, and this is also one other sign of an aerated lung. So if you see the bat wing sign and you see lung sliding, then you know that this is a normal aerated lung. So then we talk a little bit about the A-lines. So you have a probe right there on the skin. It is going through the intercostal space. These ultrasound waves are going to go hit the pleura and then bounce back, hit it again and bounce back, and hit it again and bounce back. So these are going to be causing the reverberation artifacts, which are called the lung A-lines. And we, of course, are most interested in the B lines, and you can see all these ray-like hypoechoic vertical artifacts, which are emanating from the pleural line. They move with the lung sliding, they extend to the far field. They can be associated with a thickened pleura, so that is one of the things people need to remember. But if you notice 3 or more B lines in more than 2 zones bilaterally, it is consistent with pulmonary congestion. This is nothing but artifact from interstitial edema. And here is an example of severe interstitial edema. You see multiple B lines coming out to the periphery. Here there is interstitial edema moving on to areas of consolidation. So just a couple of examples there. And it is really important for us to know that the bilateral B lines is much more sensitive and specific, even compared to pro-BNP, which is where we actually love to hang our hats on. Look at the sensitivity for B lines, 95% as to 92%, and specificity is 100% as opposed to 89%. And when obviously much better when it comes to physical exam and chest x-ray, where the sensitivity ranges between 50 to 60%. It's an independent predictor of worsening heart failure, and you can actually utilize it for prognosticating a patient. And a lot of you, almost all of you, are familiar with looking at IVC. If the IVC diameter is less than 2.1 centimeter and it collapses about 1 to 2 centimeters from the cavo-atrial junction, it is consistent with normal PA pressures with an average or a mean of 3. If it is more than 2.1 centimeters and it is not collapsing, it is associated with a mean RA pressure of 15. And anything that falls in between these two is intermediate, and we give it a mean of 8 millimeters mercury. And some of the unique features of POCUS devices are things that we need to take into consideration. The probe technology is extremely unique. It's got silicon chip array instead of the piezoelectric crystals, so the chances of destruction of the probe is a lot less. Image quality is reasonably good if it is a trained provider. Harmonic imaging is available. Wireless and Bluetooth technology, they allow the transducer recognition, battery charging, image transfer, and touchscreen technology is standard. So in addition, cloud-based interpretation is possible for remote viewing. And here are some advantages and barriers to POCUS. One of the biggest barriers is language. If the patient doesn't understand, cannot follow, that is one of the barriers. Inability to transmit images, even though you have a really good POCUS exam. Acquisition difficulty, diagnostic uncertainty, and the patient is not happy about the POCUS exam findings and might not believe it. So that's another thing. And the training, obviously, as we spoke about, and access to an expert sonographer. So here are some of the POCUS evaluations, POCUS findings, and possible diagnoses. And this has come from Dr. Sengupta's POCUS workbook from Jack. It's a fantastic read. It's very easy. So I would recommend that all of you just look through it. And everybody asked me about the billing code, and obviously there is a billing code for the cardiac as well as thoracic. So if you do a cardiopulmonary POCUS, the global payment is $125 plus almost $90. So about $215. So this is something that can be considered. Now let us switch gears and meet our patient. 73-year-old woman who presented with chest pain, shortness of breath, and lower extremity edema. Past medical history is significant for hypertension, hyperlipidemia, diabetes, and CVA. She was admitted for hypertensive emergency and an urgent left heart cath given the chest pain with ECG abnormalities. The left heart cath revealed 3-vessel CAD. A PCI was not performed as the team decided to discuss surgical options with the patient. The formal echo was done as part of cardiac workup. You can see significant LVH. There is a pericardial effusion. It is small to moderate. It appears to be circumferential. And so obviously we reviewed the previous echoes. The LVH was still there, left atrial enlargement was there, and pericardial effusion was noted even previously. It could all be consistent with hypertensive heart disease, but it could also represent amyloid. The LV strain, however, a global longitudinal strain was negative 25%, so this was not consistent with amyloid. But we've seen otherwise anyways. The plan was to embark on amyloid workup and to obtain a cardiac MR. You should always ask yourself, what is the cause when you see stuff like that? And we have to work like detectives trying to find out what may have caused this. So here is a cardiac MR, and that demonstrated a nice, beautiful dissection flap. And here is a stat CTA, once again demonstrating a dissection flap just above the sinotubular junction, so consistent with type A dissection. So a formal echo was immediately done to make sure that there was no significant aortic regurgitation. And here the dissection flap was seen in the ascending as well as portions of the descending aorta. And there was no significant aortic regurgitation. There was trivial to mild AR. She underwent a successful emergent surgery with a repair of type A dissection. So she had an elephant trunk along with resuspension of aortic valve commissure. She had a cabbage. She had a complex multi-layered sternal wound closure. Postoperative day and 4 had normal. The echo showed normal LV function, mildly reduced RV systolic function without any pericardial effusion. Postoperative day to 6, she had a few complications. She wasn't thriving. She was weak. She was reintubated for hypoxic respiratory failure, bronch rebuilt, group A strep, broad spectrum antibiotics were begun. She was hypotensive on post-op day 9. A bedside POCUS was performed. And this was performed to look for LV and RV size. It's a very goal-directed echo, and to look for a pericardial effusion. You can see the right atrium significantly collapsing and the RV also collapsing at end expiration. So immediately the OR was activated for emergent mediastinal washout. So they wanted another formal echo prior to taking the patient. Remember, postoperative day 4 echo was also normal, but between just that to day 9, there was this huge effusion that developed. So she actually underwent a mediastinal washout, removing about 500 ml of clot adherent to RA and RB with serosanguinous pericardial effusion. And she had a very long, complicated course and was discharged to a long-term facility due to complications of needing a PEG tube and a trach. So the POCUS here was very, very helpful. It was something that actually changed the course of the patient's management. She was able to be taken to the OR right away. So I usually tell the fellows and others that you need to understand the basic views, you need to practice, you understand what normal looks like, so you can actually figure out if things are abnormal or out of the ordinary. And if you have to do segmental scanning, if you can't get the whole image in the view, it's okay to take sequential images. So I'm here going to switch gears. I have been very lucky to participate in the POCUS-Care trial with Dr. Sengupta and the others. And it was also wonderful to be able to present it as late-breaking clinical trials at Euro Echo. So a lot of us know that dyspnea is one of the most frequently encountered presenting symptoms in clinical medicine. Almost 1 out of every 10 hospitalized patients have dyspnea at rest, and cardiopulmonary etiologies of dyspnea are particularly concerning because they're linked to poor clinical outcomes, frequent hospital readmissions, and an increased mortality. So the traditional approaches to dyspnea management involve distinguishing cardiac from the non-cardiac, using medical history, physical examination, and also all of which directs certain initial investigations, especially pro-BNP, anti-pro-BNP. Emerging technologies such as POCUS, when integrated into bedside clinical exam, has shown enhancement of cardiopulmonary assessment, and they have outperformed traditional stethoscope-based evaluation. So despite a huge potential that we know and we have talked about, adoption is still very inconsistent. Even though ACC, ASC, they endorse the value of cardiopulmonary POCUS, there are still barriers and not too many people actually utilize, because there are still barriers pertaining to training, competency development, as well as utilization. So when you look at a systematic review assessing the impact of POCUS on clinical decision-making, hospital length of stay, and mortality in internal medicine, there is scarcity of studies with significant methodologic limitations, indicating a lack of robust evidence. And so to address this gap, we actually aim to study a collaboration between hospitalists, sonographers, and cardiologists at a distance to implement a hospitalist-driven bedside POCUS evaluation in patients who were admitted with undifferentiated dyspnea. So here, the dyspnea could be secondary to either cardiac causes or pulmonary causes. So the study was established as a QI initiative to integrate the cardiopulmonary POCUS assessment into traditional assessment of patients admitted with undifferentiated dyspnea. And we really were curious to look at the outcomes. So the part of the QI initiative, we actually offered training to the hospitalists. They were trained one-on-one on live models as to how to perform POCUS examination. They were also given access to educational videos. All the education was provided on one-on-one basis for about 3 months. The QI process actually, the design is extremely interesting. It's a very pragmatic design, and it is called step wedge cluster randomized design. So here, a cluster of physicians who are not performing POCUS as a routine standard of care was used as a control group. And this was followed by randomized clusters of physicians utilizing cardiovascular POCUS as the interventional group. This continued till all the clusters of physicians onboarding over a specific time till everybody was included in the QI process. It allowed equal timeliness to study the clusters of how the control, which is the traditional group, as well as the POCUS groups, actually worked. The patients who were involved in the POCUS group received a diagnostic POCUS exam on the first day of admission. A POCUS trained sonographer was available for them in case they needed help if there were challenges in performing the POCUS by the hospitalists. They were consecutively enrolled when a sonographer team was available during the weekdays from 8 to 5. Inclusion criteria were any patient over the age of 18, and the exclusion criteria were very, very clear. We obviously don't follow pediatric patients, so anybody less than 18 years of age were excluded. If somebody has shortness of breath from known trauma, they were excluded. If there was limited code status, patients' refusal of POCUS, as well as clinically unstable patients where the heart rates were very high, if their systolic blood pressures were less than 85, or if their saturations were less than 92%. A written consent was waived by the IRB as this was a QI initiative. And the primary and secondary outcomes were listed here on this slide. We were looking for a 15% reduction in the hospital length of stay. And for secondary outcomes, we were looking at the total hospitalization costs. So let me just go over how we enrolled and go over the study design. Following this screening, about 216 patients were randomized. 131 to the traditional approach and 85 to the POCUS group. Amongst these patients, about 7 were rehospitalized, so they were excluded. That left us with 124 patients. And 1 patient on this POCUS group was rehospitalized, so here we were left with 84 patients. We did a propensity score matching to account for cardiac arrhythmias, for diabetes, for pulmonary comorbidities, as well as venous thromboembolism. And that left us with 84 patients in each group, and we looked at the length of stay as the endpoint. And this is clinical characteristics of unmatched cohort. So just like how I discussed, this is mostly the matching was performed to account for these confounding variables. And here are the clinical characteristics of the matched cohort. And this actually showed that the matched cohort was very close. There was no significant differences, as you can see. So here, if you look at the age, they were equally matched, and there was 36% of males in the POCUS group and 42% in the traditional group. But if you look at the past cardiac conditions, coronary disease was something that we looked at. And I think let me just see how many. It was about 9% in the traditional group and about 7% in the POCUS group. If you actually look at the transthoracic echo, POCUS group had 66% who also had transthoracic echo performed. And in the traditional group, obviously, 69% had a transthoracic echo that was performed. We actually also found that when you looked at LVEF, it was less than 50% in 27% of the patients with the POCUS group and 26% of patients in the traditional group, and that was not significantly different. B lines were noted in 60% of the patients with POCUS group and about only one patient in the traditional group. And the most common diagnoses were heart failure, 64% in POCUS, 63% in traditional, pulmonary disease, 36% in POCUS, 31% in traditional, renal disease, 13% in POCUS, 7%. And as I have mentioned, CAD, 7% in POCUS and 9.8% in the traditional. So I briefly jumped over the POCUS components. We did the cardiac POCUS, lung POCUS, and then also looked at the subcostal images to look at IVC. And we subdivided the lung POCUS into these areas. Now, the results were extremely interesting. As the population was a little skewed to the right, we actually utilized gamma mixture model analysis to assess for the length of stay. We found that the gamma mixture model, if you look at this pictorial, actually had two components when we look at panel A. So there is this red component and this blue component, which is component subgroup 1 or component 2 or subgroup 2 with an overlap here, which shared both characteristics. And if you look at the POCUS, it is very, very similar as well. And if you look at both of the fitting, this black line actually looked at the significant fitting for both the models, both for the control as well as the POCUS group. And here, if you looked at median length of stay in the POCUS group, it was tight, but it's only 5.6 days. Whereas if you looked at the control group, it was 6.5 days. And secondary subgroup had a much longer length of stay. This one in the blue lines had much longer lengths of stay. In comparison, the POCUS group, if you just looked at the 30 patients in whom POCUS actually aided in decision making, this is an extremely interesting pictorial. It actually showed that where the POCUS aided in decision making, those patients were discharged at a much shorter, they had a much shorter length of stay. And the first subgroup had a median length of stay, again, like I said, of 5.6 days. And then the latter half had 6.7, 6.5 days, so close to a day difference. Here, when you actually look at the analysis of how the impact of POCUS was on discharge metrics, and once again, extremely interesting. Patients in whom POCUS resulted a change in medical decision making experienced higher rates of discharge. And here you can see the steep rise in this orange curve. And then here, the log length of stay actually showed that there is a much more cumulative probability of getting discharged much sooner. Whereas if the POCUS did not aid in decision making, this mirrored pretty much the traditional subgroup. So there really wasn't a difference. So this was actually very, very interesting. And then if you look at the analysis of discharge likelihood ratio, the cumulative discharge probability here, of course, approached one much, much sooner. And here, the group had, if the decision was utilized, the group had a much higher discharge likelihood ratio as opposed to where the POCUS, even though the POCUS was done and the decision was not utilized to discharge the patients. Now, just moving on to the hospital total cost of stay. And this is where it gets to be a little bit more interesting. This is somewhat similar to some of the other studies that have utilized POCUS to look at the hospital length of stay and total cost of stay. Here, once again, we have utilized gamma mixture models, and you can see that the cumulative discharge probability the total cost of stay was, even though it is much higher initially within the POCUS group as opposed to the traditional group, patients got discharged much, much sooner. And once again, how we had actually looked at the prior model, once again, there are subgroups. So there is this red subgroup, there is this blue subgroup with an overlap group in both of these traditional as well as the POCUS-driven groups. And if you look at the cumulative costs and the money saved, it truly is interesting because here you can see that the orange is the POCUS group. There is a steep rise, and which actually slows down somewhere between 20 to 40 days, and then plateaus out around 60 and stays around the same plateau around 80. Whereas if you look at the blue line, which is the traditional group, it again moves up very, very steeply and a little less steeper between 20 to 60 to 80 days. But look at how long it takes before it plateaus out around 80 days. And so this early plateau here actually results in the cost savings. And then here you can see that there is a significant, almost double the difference in cost savings between the POCUS and the traditional groups. And some of the challenges in implementation of POCUS in our study, only 20% of the hospitalists were able to perform POCUS. There was lack of technical proficiency, there was lack of time, and inadequate quality assurance because they did not feel comfortable with reviewing all of the archived images. Some of the limitations pertaining to stepped wedge cluster design, randomized trial, even though it's fantastic, it's extremely pragmatic, especially when it comes to heterogeneity in your patient population that gets admitted. And this is one of the most common trial designs that we utilize. It can still lead to clinical cluster imbalances, potential for contamination, and complex data analysis. And remember, this is a single center study, and we are lucky to have research sonographers and sonographer availability. The cost of hospitalization cost calculated was on claims billed rather than claims collected. And we did not assess whether there were any limitations on the patient's perspective when it comes to adherence to GDMT. We also did not look at some of the other heart failure interventions such as phase 1 or 2 cardiac rehab and whether any of them needed advanced heart failure therapies. In conclusions, we felt that the POCUS was feasible. It improved triage and management of patients with undifferentiated dyspnea. It reduced hospital length of stay with realization of significant cost savings. And these support wider adoption of POCUS in hospitals to optimize patient outcomes and to lower hospitalization costs. And we need large multi-center studies to look at these findings and validate them. And given the budget constraints, I think policymakers are not just talking about the local, I'm now talking about the federal government. They should evaluate the cost effectiveness of integrating POCUS into standard of care. Take-home points, multiple studies have modeled potential POCUS cost savings by reducing downstream testing or standard echo. It may serve as a gatekeeper for echo, including those deemed rarely appropriate by appropriate use criteria. They may identify essential pathology, even in rarely appropriate indications, in addition to ruling out things. So we have to be prepared for that. It's the cornerstone now of bedside diagnostic cardiac assessment. And we in the cardiology community should take the responsibility of shaping future leaders and future learners. And it has excellent diagnostic and prognostic value. There is a billing code. And lastly, practice, practice, and practice. With that, I'm going to thank all of you. Thank you so much for your attention.
Thank you very much, Kamu. Very comprehensively covered, and thanks for covering the last clinical trial. If you want to bring down your slides, we can bring you back into great. So let me ask some questions which bother me quite a bit. First of all, I know we've been having the POCUS as a tool for last almost about 10 years. I mean, POCUS has been around. Well, I have actually started adopting, but it's interesting within the cardiovascular community, people do not use. Certainly at RWJ, we don't use it. At least we don't see our physicians in the community. And today we have a tremendous group of people here. Why is that so? Number one. Number two, since the cost has reduced, I mean, a Littman costs you, I do not know, I didn't buy a Littman for the last about 7 or 8 years. So as a disclaimer, I don't use stethoscope anymore. I use only point of care ultrasound in my clinical practice. But they're, I think, $2,000 or $3,000 point of care ultrasound. And why is it people don't use it?
I think it boils down to education and training, which are like the biggest things. And also, people need to be open to utilize newer technology. And the last thing is many of the people are not aware that there is a billing code, because if you actually can store it and you can interpret it, you can actually bill for it. And so maybe we can also drive it from the economics perspective that, hey, if you do this, you can certainly bill for that. And maybe that'll change some of the attitudes. From the general internal medicine folks, it has always been that there aren't guidelines, there hasn't been proper training, even though there is a great push now within their communities, even in training, a lot of people are using POCUS. But also, how do you keep up to assess? Wall motion would be very, very tough. So they need to get the proper training. So if you're uncomfortable doing something and not being able to utilize it for patient management, I think it's a huge limitation.
Yeah, I mean, this is important. I think we have our colleague, Dr. Googling, joining in and saying that stethoscope is obsolete. Well, I mean, I certainly feel like if you have the choice to use a POCUS versus stethoscope, I would use POCUS for sure. And if you have an access to it, I would use it. Please feel free to post your comments so that I can bring them up. But I want to ask you one more question. So it's a very interesting situation. So I've seen this. I mean, sometimes we do things because we are in a habit of doing, right? And we don't question. So I'm not going to quote who it was. Uh, uh, there was once a stress test being done, and this is an exercise stress echocardiography. And the exercise stress echocardiography, the baseline echo images are obtained. And I found that the physician was still auscultating the patient. And I asked him, what were you listening to? And he said, I was looking for aortic stenosis of the hookah. But I said, you have the images here. So sometimes what I'm trying to bring in is, I think maybe we just get in a habit of doing something because we don't want to give up that habit. And it's good to have good habits, but in this instant, I think it is very difficult to untrain ourselves from what we've been trained. And I was trained also on stethoscope, right? My exams were on stethoscope, S2OS split, and so on and so forth. I mean, there's so many, and still we get asked a lot of questions in boards. So I think one is the habit, right? And the culture of has probably is taking some time. The second thing I also feel, Kamal, you pointed out very well that incentives, right? You need an incentive to do it. But I think that my biggest incentive is I get a confidence in diagnosing, right? Because if how much pride you can have once you have a confidence and you do something and you discover something, and the joy of finding and communicating it to the patient. And that's what I find is the most gratifying element of discovery on the bedside. So I wish we can bring back this. And I'm actually very proud that tomorrow we're going to have a presentation in the auditorium. We are celebrating one of our fellows, Sean Chawla, was able to pick up a life-threatening emergency of aortic dissection on one of our patients. And Sean was my fellow in the clinic, and we repeatedly would do point-of-care ultrasound. And it made a difference because he was able to change a code, which was a STEMI code, and stop the bus from going to the cath lab, and instead direct the bus to the OR, and within 5 minutes, and with a confidence. And he didn't have any other history, but the confidence of the image was what led to that patient. And I think we're going to celebrate. The patient is going to be here with the family, and I think that's a great celebration. But I would like to bring something to our community here. Don't wait for your others to buy you an equipment. Invest yourself, and maybe utilize it as a tax deduction. But that will be the best investment and best thing that you would do for your own patients. I'm sorry, I probably am a little bit more passionate. There are two questions on the chat. What are your thoughts about that? And then I'll present through the questions.
Dr. Verma has put in the chat, in your practice for patients with palliated congenital heart disease and significant residual structural heart disease, does that hamper acquisition and interpretation by POCUS? When it comes to complex congenital heart disease, I honestly think a dedicated full echo is needed because you need to make sure you're not missing anything. And also you may need to look at connections really carefully. But if you're going to be serially following them, say to look at RV size or looking at PA systolic pressure or TR velocity, or even just looking at the pulmonary valve VTI, I think an interpretation by POCUS in the clinic would be okay. So it's going to be a mix and match. Would you agree, Dr. Sengupta?
Agree. Yep.
Yeah.
Agree.
Sasha East, Dr. East was asking if impeller position makes up a decent portion of our stat echoes. Do you think POCUS is up to the task of tracking devices such as Impella? I completely agree. I think we can certainly utilize POCUS. And in fact, if those get put in the cloud, or if we can even put them in ISCB, we can bill for them.
I think
Um,
that's a great suggestion. I think we should think about doing it because it's so important that we do that. And we can do as many times, as frequently as you want it.
yes.
Yeah.
And Dr. Albert also agrees. And Choni, I have to say, now we can do impeller positioning in the morning and in the evening every day. If we have the POCUS. So Dr. Shah has one question in the chat. Does POCUS have a role in outpatient office practice? Absolutely.
So,
I utilize POCUS when I have any patient, in fact, partly to rule out and partly to allow the patient uh, to have peace of mind, to allow them to know that they don't have significant aortic stenosis or significant aortic regurg. It has been very helpful because they can actually see it as well. And the part B of the question is for new patients and known CHF patients, where can you tackle them before getting to the point of admission? There have been multiple studies showing that if you actually look at the IVC diameter and IVC collapse, you can predict how quickly they can get hospitalized. And these have been done both on the inpatient side as well as the clinical outpatient side. And on the inpatient side, if they are somewhere at a mean RA pressure of 8, those are the patients who, and or a mean RA pressure of 15, those are the patients who seem to keep getting readmitted. If we, Dr. Hamirani, if we switch from POCUS to limited echo, are we losing revenue? No, you can bill it as a limited echo. POCUS is still echo. As long as you define how limited you want it to be, because it really has to help with the patient management decisions, you can still bill for it. I
so
don't
just,
think we'd be
I,
losing too much revenue.
yes, but let me also make a qualifier. So the person who reads the study, their competency and their quality and their proficiency defines their ability to bill for it. What I'm trying to say that if you do not have your certification and competency to be able to do cardiac focus, you cannot bill for it, right? Because you need to have a quality assurance on what you're trying to do. But you can do POCUS as an extension of physical evaluation without requiring to bill. I just want to make sure that you understand because there you are, just like you use a stethoscope, you're using it as a surrogate of extension of physical examination, which anybody can do. Obviously, you need a little bit of training, but for billing, you need competency, proficiency, and the skill set for cardiac focus. And particularly for the limited echo is defined by a cardiac level 2 trained echocardiographer can bill for a limited echo, to call it a limited echo. So now the thing is, it's no longer the device that defines what is POCUS or what is a limited echo. It is basically the person who reads and interpret defines the ability to bill for a certain code. I also wanted to make sure that we answer that. Are we going to lose revenue? Well, most in the hospital, no, because it's all DRG. So the hospital is not going to, in fact, you'll make it more cost effective, efficient, faster decision making. And I think hospital is, as long as there is a system for us to be able to honor efficiency. So there may be different metrics of what's the incentive when you take a good quality work, faster discharge, that needs to be defined by the hospital or our leadership. And if that kind of incentive is available, then I think you will never see or ask for whether it will be a loss to your own personal work RVU, because you're going to be gifted in some way or the other. Hospital is not going to get paid anyway because it's under DRG. So that's an important. Is there a template for interpretation? Kamu, you want to go ahead?
Yeah, we typically utilize the same template that we use from the ASC. So if it is a limited echo, say you just looking at the LB and RB, you're going to go through the same exact stuff that you would use as for card-based echo. And so you can still utilize a template for that if it gets into ISCB. The other thing is, if it gets into cloud, we can always create similar stuff to use as a template. The other thing is, our fellows can actually scan and they can put all of these images in the cloud. If they want us to interpret, we are more than happy to interpret as well.
Fantastic. I think we are already 7 minutes over time. Can we make this available in Epic? You can type it up and make it available in the Epic. It's again a work in progress. Can be done, Yasmin. We can look into standardizing a process. This year will be a big POCUS initiative. In fact, the health system is going in for finalization of the POCUS vendor. So I think you will see some of these activities coming to fruition, hopefully this year.
So I honestly think it'll be great for us to learn about some of the barriers in true implementation as well. So I think we really should look into that.
Yes. With that, thank you very much, Kamub. It was wonderful to have you present with us, and we look forward to getting this paper published very soon, and more projects this year for us. Particularly, one of the projects that I'm looking forward to taking your help is the RO1, which has an aim to be able to define high-risk ACS, those people that need to go to cath lab and should not be waiting. Because right now we can have POCUS and help us define subsets of people who are high risk and need to go to the cath lab. There's a subset of patient called as occlusion MI. Maybe we'll have another talk one day about this, but more to come. So there's a lot of activity and a lot of advances. With that, thank you all. Thank you, Kamu. Have a good night.
Thank you, everybody. Good night.